So welcome back after your bio break. And I'd like to introduce this panel, which is going to be chaired by Dr. Alex Singer, and he's going to introduce the rest of the panel. So this is our second session on integrated care, and we've got a bang-up speaker list. So without further ado, I'll turn it over to my colleague, Dr. Alex Singer, who is sitting in Manitoba and is a family physician. Thanks.
Hi. So thanks, Sabrina. I don't know if I'm supposed to introduce myself, but I'm Alex Singer. I'm a family doc, and I'm also the Director of Research and Quality Improvement for the Department of Family Medicine here at the University of Manitoba. And so I'm going to fire off and introduce our first speaker before we run out of time. And I've been told that I have abilities to mute him after 12 minutes. So Morgan Price is a good friend of mine and a wonderful family physician. And he's also, let me look up his bio so I don't screw it up, but I can say lots of nice things about Morgan. He's an associate professor at UBC, and I think works at the Island Medical Program. He is a family physician and works in inner city populations in Victoria, BC, and is also an adjunct professor in computer science and health informatics at the University of Victoria. I won't list all of Morgan's research interests, but I will say, which is not in his bio, that Morgan's the director of something called the Innovation Support Unit, which has been doing really awesome work in the last little while. And I will turn over this talk to Morgan to tell you about the cool things he does.
Thank you, Alex. Yeah, I'm going to talk entirely about the ISU, so it's funny that it wasn't in that bio. I'm going to share my screen for some slides here, see if this all works. And I have a whopping 12 minutes to do 45 slides. No problem, right? So the crazy title I have for today is Influencing Organizational Collaboration within BC. And I think that relates to some of the work that we're trying to do in the Primary Care Innovation Support Unit, which is really to work with different groups at different levels to see how we can work better together. And we've been around for about 3 years, really had a large expansion in the last year, and what a year to try to expand with that mandate. So I want to thank the team. I'm really just their ball talking head. That's one of the roles that they've given me. And so I'm here today to be not the PR person, but to share some of the work that we're doing. And by way of disclosure, we are funded through the Ministry of Health almost exclusively now. And just as a mitigation, that's being funded. All the funding and agreements are managed through the university, so it's nothing direct. I love this quote from Wynton Marsalis about work intention. And I think as we talk about influencing behavior and working together, it's a good one. If there's no tension, then you're not serious about the work you're doing, which I think is cool. So I'm going to talk about 3 levels of different types of collaboration that we've been trying to influence at the micro, meso, and macro levels. And these are not things that we've done exclusively, but we've been working with people on them. And then spend a minute at the end just to do a bit of reflection on why this is important. So team mapping is where we started way pre-pandemic. And this is really a facilitated workshop where a primary care team works together on how they want to work together. And that's been kind of our mantra to define a primary care team. We used to do this in person. People get together, buy some dinner, or buy some lunch. Usually there was food involved somehow. And lots of Post-it notes in a big 4-foot circle where people would talk about simulated cases like Sue and start to figure out how they would work together to support Sue's various health needs as we progress through multiple scenarios. And obviously this year we pivoted away from Post-it notes to virtual. And so we now have an online version that's so much cleaner. But it's very different to run something like this not in person. And some people show up on their tablets and some people try to show up on their phones and other people don't share their screen or they step away for a while. It's very, very, very different. But team mapping was really designed as a way to help people learn about how they want to work together, do that in a patient-centered way, and work through some of those tensions, be they specific or explicit, or those that were implicit, that were perhaps making it challenging for people to figure out how they want to work together. The second example I want to give you is the example of PAC mapping. And this grew very much out of team mapping. So this is primary and community care mapping. So if you think of team mapping as a circle, we map for a team around a patient, and that might be useful in any one of these acronyms, from a community health center to an urgent and primary care center to a patient medical home. PAC mapping is really designed to be more at community level. So pulling back out of one team and now talking about how care is delivered for a community across multiple teams. And in BC, we kind of talk about primary care networks and our SCSPs and how they might overlap and work, not necessarily as a team, but coordinate service for a population. And again, these are fairly interactive. We work through different cases. And here's an example map. I'm going to spend a little bit more time on this one. What we do here is we map different personas, again, using simulated cases to illustrate the populations. And we ask people what ideas they may have that would help address that particular person's service need that we've defined as a gap. And you can see on the map, different ideas have popped up and they're color-coded to match the different personas. So Frankie's are in orange and Howard's are in yellow, Johnny's are in blue. And as we have a discussion across a group, this may be members of a network, members from the health authority, other decision makers in the community, even municipal government can be involved. We talk about what are the realistic options and start to illustrate how we can fill those gaps. And on the right-hand side, there's lots of potential parking lot questions that we can't solve in the moment. So we capture those, and then we may capture other ideas at the bottom. PAC mapping is a neat way to get people, again, to discuss how they want to work together and influence that collaboration. I'm finding it's increasingly more important this year, and I'll touch on that before my 12 minutes is up, Alex. With PAC mapping, we have also adapted it to do different things. So it's not just about mental health and substance use or primary care and attachment. This one's access. And so our map's a little different. Our map's actually a calendar. So we do the same thing. We're using our personas, but we're going to describe their access needs at different times of the day or week. And then through the discussion with people, we can look at different community level options that might help improve access. And you can see here, we've got a whole bunch of different ideas that have come up through discussion. And this is over an hour to 2 hour meeting. We've also, of course, it's 2020. Started in 2020 rather to look at COVID-19, and now in this year in 2021 we're doing an adaptation for immunization planning, and this one's actually got some multi-jurisdictional support, and we've got folks way back east in Manitoba who are quite keen for this one as well. And here, instead of mapping out ideas about access or mental health services, we talk about different immunization options and where geographically could they be located and what kind of service could they be. And then we use the personas to say, who can actually get there? So Sue, given her mobility issues and what kind of transport she might have, can she make it to which places? And Dorothy might have a different ability to make it only to an after work clinic because her son-in-law can drive her, but only after work. Whereas other people may have no issues getting to multiple places. And this way we can map across the community what are some of the better options for vaccine, especially when we're talking about a limited number of clinics across a community. So PAC mapping is proving to be a nice flexible approach to help communities prototype different ideas and work through different tensions across organizations who might have different ideas but aren't taking into context that diversity and trying to be inclusive about the population that we're trying to support. And so we've tried it from mental health all the way through, and now designing stuff for vaccine, immunization, and even vaccine hesitancy now. And at the macro level, the last example I'll give is our team-based care advisory group in British Columbia. This is chaired by Natasha Prodenbala, and it's a diverse group of stakeholders, multiple representation from health authorities, professional associations, divisions of family practice, really looking at how can we move primary care, team-based care forward in the province. And we've been working through this entirely virtually for this last, I think we're about 10 months ago, we were sort of reconstituted. And we've been focusing through a series of workshops on what's our shared purpose initially, why are we here, what are our goals? And then looking into the how of we want to develop this, and talking about now into this need for a large provincial collaboration plus supporting individual networks. And then been diving a lot into the what, specifically what do we want to build here. Looking at it over time, what kind of supports are needed from the early stages of team development all the way through to the sustaining and spreading. And then across different levels vertically here, from the individual at the bottom up to the sort of the provincial system. And we've got a couple of check marks on work that's already been done, and continuing to work on some of these other areas. We have a more detailed version of this that actually has ideas in every single box, but this one highlights some of the key prioritized ones that we have done through some of our facilitation tools. And that comes to the point of we've been doing this using a bunch of different online tools to try to get the discussion to build, to vote on different ideas, promote other ideas, and describe what's needed to help the change. We've done a lot of stuff in this last year like that at the ISU. And that'll take me to my last 1 minute, Alex, of reflection. And personal reflection, my last IRL event, as my son would call it, was this conference. And on the way home, I said to our ISU manager, Sarah, I said, that's it, we're done. Pandemic's going to be declared, everything's virtual from here on in. And here we are, literally a year later. In that year, we don't do virtual nearly as well as face-to-face, and that's impacting so many aspects of our lives. This is from my clinic, celebrated a few years ago, the 50th anniversary of the Kool-Aid Society. And the Kool-Aid Society has been delivering healthcare for almost all that time. The starting physician is somewhere in these photos. I won't disclose who he was, but I want to give you the stark contrast between those kind of pictures and this picture. And this is our team huddle from a week ago. We've worked together so well for many, many, many years, and yet the pressures of all this and being virtual, even those who are in the office for the day, we're all a little bit unsure. So what I've learned is that we need more process, not less, and not overly prescriptive process, but we need help working together. We have not only more tension, but we have less ability to work through tension together than we did a year ago. And not being face-to-face makes it a real challenge. So I would love to have some more discussion in the panel about what kinds of things help people work through those different tensions at all those three levels. Sorry, Alex, I went over by a minute. Thank you, everybody.
I didn't count my introduction, so by my count, you were perfect on time. So
excellent. There we go. Thank you.
All right. Thanks, Morgan. So we're going to keep going with the presentations and save the questions for the end. So the next speaker is Jennifer Baumbusch. Jennifer is an associate professor at the University of British Columbia School of Nursing. She has a Canadian Institute of Health Research Sex and Gender Science chair focused on the dynamics of caregiving in aging society, and directs a research program on healthcare delivery, nursing practice with older adults. Her focus in long-term residential care, family contributions to care delivery, well-being among individuals with intellectual disabilities and their families, and knowledge translation. She's got experience in critical ethnography and practice close research. Dr. Baumbusch is committed to community-based research principles through active engagement of individuals, clinicians, service providers, and organizations. So looking forward to what Dr. Baumbusch has to share with us and elucidate about these sort of many interactions. Clearly, the long-term care world has been highly affected, and patients who are frail have certainly suffered, in some ways, probably the brunt of this last year's devastatingness. So please go ahead and let us know what you're going to tell us.
Thanks, Alex. So I'll also work on my screen sharing skills. And let's go. Okay, great. So I'm I am going to try and also do this in 12 minutes. And Alex, I hope you give me a wave when I get close to the end of my time. I'm a talker. And today I was really going to focus on long-term care, the next chapter. So I have worked in and around the long-term care sector for the last 25 years. And I'm currently do research mainly in this area. So yeah, I was very pleased to be able to bring this focus to the conference. I'm a big believer in not only looking where we are, but looking where we came from. And I think in long-term care, that's particularly important. We all of a sudden have a lot of people very interested in this sector. And I think it's so important to understand what was happening before the pandemic hit, because it helps us understand a little bit about where we are, but also informs where we want to go. In British Columbia, we're lucky. We had a historian researcher write a whole book about the history of the long-term care sector in our province, Dr. Megan Davies, and it's one of my favorite books because it's so interesting to read how our seniors care sector grew out of being a resource province. And there's something to be said for really understanding the local creation of this sector and how it plays out today. So in June 2019, my friend and colleague Jen Lyle from Safe Care BC was speaking to the Standing Committee on Health with the Canadian Senate, and she told them long-term care is under-resourced, understaffed, and under pressure. And little did Jen know that 6 months later, she would be leading the collection of PPE, 1 million pieces of PPE for the seniors care sector. And I think when we think about fragmentation of our system, there is no better example than how when the pandemic came, the focus of resources went to acute care, understandably to some extent, but left the seniors care sector sort of to figure things out on their own. And I had former students who are directors of care emailing me, asking me, Jennifer, can you get us PPE for our staff, for our families? And there's just a desperation there. And I've pointed out here 3 of the main issues that have been talked about a lot over the last year: the evolution of ownership models, the evolution of the built environment, and the evolution of staffing models, and how these have all come to bear on the current situation. So where were we a year ago? So in January 2020, we were all working still really hard on person-centered care. This is part of the culture change movement that's been happening in long-term care over the past few decades, that was really looking at shifting from task-oriented, medicalized care to a very person-centered approach. So I'm sure many of you are familiar with models of care like the Eden Alternative, Butterfly House Project, Greenhouse Project, really opening up long-term care homes and integrating them better into their communities, and really making sure that we were focused on the person and making this a home and not an institution. March 2020 came and it hit hard. All of a sudden, we had infection control and public health coming into the care homes, closing the door firmly behind them to make sure nobody else could get in. March 5th was the 1-year anniversary of the outbreak at Lynn Valley Care Center, where people in our province certainly were becoming very aware of the horrendous impact of the pandemic on long-term care. We shifted from ideas around family presence to calling people essential visitors and having public health orders around that, having a single site order for staff. And by June 2020, across Canada, we had 840 outbreaks in long-term care homes across the nation. So this was a huge impact in a very short period of time, very intense on a sector that, as Jen had said, was already under-resourced, under pressure. So today, I really wanted to focus on a few of the big ideas of where do we go from here. I think there was already existing ideas and strategies around improving collaboration and integration. So I'm going to focus on those for the rest of my presentation around the built environment, the workforce, and person-centered care. So how do we design around the space and place? So one of the ideas that has been created and is being implemented worldwide are campuses of care. So these are places that offer multiple levels of care. You not only have the campus integrated into the community, but you also have people coming in and bringing your community into the care home, into the community, and having care team members have their actual offices and clinics on site. Then there's the built environment that supports integrated care. And we know a lot already about best practices for person-centered care that also align with good infection control practices, like having private rooms and bathrooms, but also things that are fulfilling for people, like having accessible outdoor spaces. One of the things I think that needs to be looked at even further around the built environment is having a fully accessible and integrated electronic health record that works across the continuum of care. So we might have electronic health records within the care home, but when we move a resident to the emergency department, those staff might not be able to access the chart. So really, these blockages around communication still exists in the same way they did 25 years ago when I was starting out as a new nurse on the floor. So we need to be looking at how do we create an electronic health record that follows people across a system that has a complex ownership model, where care homes are not necessarily owned by the health authorities, but the space and the care is contracted by the health authority. The next piece is around designing the workforce. Nurse practitioners, we have 30 years of evidence that having nurse practitioners on site at care homes are a really, really good thing. Past systematic reviews have found that the presence of nurse practitioners can decrease transfers to hospital, decrease length of stay in hospital. And Dr. Kathy McGilton at the University of Toronto School of Nursing is doing a pandemic-related program of research looking at primary care nurse practitioners on site. And she has certainly found that the nurse practitioners are decreasing fragmentation of care. They're able to support residents, staff, and families and build those connections with people who are not on site. We talked already in other presentations about leveraging tele and virtual health platforms. I think that this is a huge area. Trying to bring a frail older person to a clinic visit or to a lab or to all of, a myriad of other things that up until a year ago could, for whatever reason, only be done in person, but can now miraculously be done via virtual health is something I don't think we want to lose, and we need to evaluate what's working best. And then the last piece around the workforce is full and authentic integration of care aides, sometimes called person support workers. These care aides, they provide 80 to 90% of the hands-on care for residents, and yet are largely excluded from care planning. And we need to break down this barrier in terms of who we consider to be team members. The last piece is around designing around the person. This is my grandma and my 100-pound German Shepherd several years ago. Neither of them is with us anymore, and I'm certainly glad that my grandma didn't have to go through the pandemic, but she lived, as you can see, in a wonderful place. Behind her is something called her memory wall, which is a design in some long-term care homes where people have shelving outside their room with personal artifacts so that the staff can get to know them. The person can find their room. Hey, that's mine. That's my family photo. This is my room. And so these places do exist, and they are part of the public system. And one of the things we say sometimes in long-term care is we need to fund people, not beds. And I think we really need to embrace this moving forward. Looking at introducing individualized or direct funding models where the funding follows the person. So if a person is able to rehabilitate, move back into a community home setting, that funding will follow them, and they'll be able to access home support and adult day programs without waiting on a list for 2 or 3 years to be able to get some of those services. There are different sort of takes on individualized funding, one of which I think is a rights-based approach that is used very widely in the disability sector and should be considered moving forward in long-term care. The other thing in Canada that the pandemic did that was a good thing was, after years of asking for a caregiver benefit, all of a sudden that was a possibility. And it was introduced several months ago, the Canada Recovery Benefit. and caregivers can receive up to $500 a week for 38 weeks if they're caring for a dependent person at home. So this is an initiative that we are hoping continues on post-pandemic and is expanded, so that we're looking at ways for people to age in place, age where they want to, and that they and their caregivers or support persons have the resources to be able to do that. So that is me, and where the next chapter of long-term care might take us. Thank you.
Okay, thanks for that whirlwind, Jennifer. That and you kept it on time, so we're rolling. Okay, and for the last speaker before we get to the Q&A, it's my privilege to introduce Jessica Nadigel. Jessica is an associate professor at the Institute for Health Services and Policy Research at CIHR. She has a BSc in biochemistry and PhD in pathology from McGill, and more recently, Dr. Nadigel completed a fellowship in health system improvement from the University of Alberta. She joined the Institute for Health Services and Policy Research in 2014, where she supports the Institute's mandate by leading the design, development, and implementation of innovative research funding programs, capacity building, and knowledge mobilization activities that help to improve the health and quality of Canadians. She's working to strengthen national and international partnerships and foster and promote strategic initiatives to support the health services and policy landscape in Canada. So Jessica's going to tell us a little bit about some of CIHR's work, I imagine, which is very important. And many of us, she'll see many of the grants from probably some of the people in the audience. So take it away.
Great, thanks, Alex. And I'll do the screen sharing. Great. So like Alex said, I'm taking a little bit of a different lens here, coming at this as a research funder, but hoping to talk about how we can accelerate integration of care through research innovation. And just briefly, my talk today will go through the need for integrated care research, talk about how we can achieve impact with this type of research, and then look ahead to see how these various factors play into our Institute's upcoming strategic plan and CIHR's newly released strategic plan. So I don't think I need to convince anyone here today. We all know that if we really want to achieve high quality patient-centered care, then we really need to move towards a more integrated care system, and both integrated care across the health sector, but also in terms of integrating across traditional boundaries. So thinking about linking healthcare with preventive care as well as social care. And we've heard over the last 2 days some really great models or programs where this has been working well, some of the barriers that still we need to overcome, and some of the work that's still left to do. But the bigger question for us as research funders is really, how can we support this type of research? So the first thing that we need to know is that it's actually a priority of our community. And if you actually look back on the past 3 strategic plans from our institute, you can see that integrated care is actually incorporated within all 3. So under Dr. Morris Baer, we had linking care across place, time, and setting, as well as linking public health to health services. With Dr. Colleen Flood, we had access to appropriate care across the continuum. And then with Dr. Robin Tablin, we had learning health systems, of which integrated care is incorporated within that. So call different things, but you can see that it's quite prominent within all 3. But we need to look beyond this, right? So just because it's a priority doesn't actually mean that the research we fund will make its way into policy or practice. So we really need to think about, how do we ensure that this research that we fund has impact? And there's a few lessons that we've learned along the way that I'm hoping to share with you, some of which have actually been discussed over the last 2 days, but you'll see we'll pull them all together using some examples of some of the most major initiatives that we've funded over the last few years. So the first thing we know is that to achieve impact, we really need multi-jurisdictional interdisciplinary teams. So a really fantastic example where this was done well were the community-based primary healthcare innovation teams that were funded. And these teams did a fantastic job of really building linkages between the researchers and other stakeholders across jurisdictions and their disciplines, really to ensure that the various contexts, both in terms of location and setting, but also professions, were considered within the research. And we know that this is especially needed when we want to tackle big health system challenges like integration of care. We're going to need these various contexts being considered as we develop our solutions. So also when we're thinking about teams, we know that we need really meaningful partner engagement. An example where this also was really prominent was in our Transitions in Care initiative, where we felt that the need to, as part of the research team, I should say, there was a really strong need to have patients, family members, or caregivers, as well as decision makers and healthcare providers on the team, so that you had all those voices sitting at the table, really co-creating, co-producing the research alongside the researcher, with the ultimate goal of leading to a really strong integrated knowledge translation approach. So my next example is the Primary and Integrated Healthcare Innovations Network. So this was an entire network that was developed to support integrated care, placing primary care at the center. There are 12 networks across the country, and they were funded in terms of their network infrastructure, but also their research. And the point that I want to make here is that all the research stemming from this network was directly linked to healthcare priorities. So this was coming at it from a top-down approach, priorities developed from were direct priorities from the ministries of health. And it was designed this way to ensure relevance to the health system needs. So the last example I just want to mention here is about embedding researchers within health system organizations. So we know that when we talked about having researchers and other decision makers as part of the team, but really another way to provide impact is to really embed these researchers within health system organizations. So you're placing the research capacity at the coalface of policy and decision making to really help these health system organizations generate and use timely, relevant evidence when making their decisions. You can see two examples here. So our Health System Impact Fellowship, which is really about placing PhDs and postdocs within health system organizations, as well as the Embedded Clinician Researcher Award, which was placing early and mid-career clinician researchers within health system organizations. So we can put all of these sort of design elements or key ingredients in place, but the other part to all of this is actually being able to assess impact. And if anyone's tried to do this, you know it's a really challenging thing to do. So to help with that, the Canadian Health Services and Policy Research Alliance actually developed the Making an Impact framework to assess the impact of health services and policy research on decision making. So there are three components within this framework. So if you want to demonstrate your impact, you can use the pathways to impact. If you're looking to measure your impact, there's a suite of indicators that you can use. And if you're looking to communicate your impact, you can use one of the tools like the impact narrative. So this is really looking at going beyond just communicating your normal research results, but really getting at the actual impact that your research has had. So if we pull all these together, you can see our list of key ingredients that as research funders that we look at in order to support impactful research. And as we were developing our strategic plan, we were really looking at these key elements to see how we can incorporate them within the plan. So if anyone was at the CHSPR conference last year, you know that we came to consult on our strategic plan and the upcoming priorities. And it was really an extensive consultation process from really talking to and consulting with trainees all the way to senior career researchers, health system partners, decision makers, ministries of health, patients, the public, and healthcare providers. And we're thrilled to say our plan will actually be launched in the coming months. The title of the plan is to accelerate health system transformation through research to achieve the quadruple aim and health equity for all, with the quadruple aim really being about improved patient and provider experience, better population health, and improved value. So you're getting actually a sneak peek at our upcoming plan and the 4 priorities within. So our first priority is to accelerate the discovery of innovations that transform healthcare delivery systems to achieve the quadruple aim and improve health equity for all. So this is really about generating the evidence on some of those macro health system challenges, like how to manage, finance, and deliver care. There are 4 prioritized areas for attention, and I'm sure everyone will be thrilled to see that integration of care is top of the list. So really looking at continuity of care as well as integrated delivery systems. Also, we have primary home and community-based care, long-term care, and the healthcare workforce. But we know if we really want to move the bar within these areas, we also need to go back to what I said about integrating care across boundaries. So really catalyzing research between health services and population health, to really have those upstream prevention determinants incorporated within delivery systems. And to support this particular priority area, we know we have to look back on some of those key impact ingredients and think about developing and supporting really large-scale, multidisciplinary, multi-sectoral, multi-jurisdictional research programs that can really tackle these areas of high interest. Our second priority is to modernize the healthcare system with digital health solutions and data science. So this is really about supporting and implementing digital health solutions within care delivery settings, but also in partnership with others, really continuing to build a strong digital health ecosystem and digital health infrastructure. One example within this particular priority is, and that's actually, I would say, been really highlighted over the last year, are virtual care options. And I just wanted to mention that we've actually been partnering with the CMA Foundations to support more than $2.5 million in virtual care research. And for anyone working in this area, there's actually an open priority announcement right now, so please go check that out. Our third priority area is to integrate evidence into health services and policy decisions for improved health system performance and outcome. So this is really trying to accelerate the development of learning health systems across the country that can continually integrate, mobilize relevant, high quality, timely evidence into programs, practice, and policies. We know this isn't easy. We know that there's a huge gap between actually research and practice and policy. But if we want to bridge that gap, we need to continue to develop programs that really address health system and patient priorities. And we know we need to continue to support really strong and meaningful engagement of all stakeholders within the research process. We also know if we want to accelerate the path from evidence to impact, we need to support effective knowledge mobilization. So really ensuring a strong emphasis on implementation science, dissemination, and knowledge translation. And then also going back to that making an impact framework, we need to use tools like this to really understand, measure, and communicate the research that we're funding. Our last priority area is to strengthen capacity for evidence-informed health system transformation. So we have a fantastic health services and policy research workforce, but we really need to continue to train and support these individuals to tackle complex health system challenges like integrated care. I should also say for that, we need to continue to also ensure that we're embedding researchers within health system organizations and continue to focus on those types of research programs. And then just in conclusion, I wanted to mention CIHR's newly released 10-year strategic plan. So there are 5 priorities. You can see them listed on the screen, but I wanted to highlight priority E, integrate evidence into health decisions. There are 3 strategies under this priority, so it's really about knowledge mobilization, maximizing results for Canadians, and strengthening Canada's health system through innovation. And I think the health services and policy research community is really primed to tackle all 5 of CIHR's new priority areas. But if you think about all of CIHR's community, you're really best placed to lead on priority E. And I think as the Institute of Health Services and Policy Research, we are thrilled to see this priority in CIHR's strategic plan and really excited to see our community shine and really help CIHR achieve this priority. And
Okay.
that's it. Thank you.
All right. Thanks, Jessica. Appreciate it. So I'm just gonna remind everyone that's watching to go onto the Slido and start putting in some questions, start voting on the questions that you want to see. We're gonna have a pause before we launch into the questions. I'm going to invite Kevin Turner, who is a patient partner that works with me on a study that, or not a study actually, it's a project, a program. We're not sure exactly what it is, but it relates to e-consult in Manitoba. We've successfully scaled up a service that was started in Ontario, and a few years back we invited Kevin to participate, and he has been just a wonderful addition. Let me read off his bio. Kevin, I think, is retired, worked in the health services or financial services industry, and lives in Winnipeg, where I am. And he's married with 2 grown-up children. And I talked about e-consult. And he's also now a consultant or a patient partner with the Briere Research Institute in Ottawa, which is where the e-consult Center of Excellence is, and a patient partner with the collaborative out that we're working with from the University of Sherbrooke that includes 4 other provinces. And he also works with the Manitoba Institute for Patient Safety. So Kevin's going to give us a little bit of reflections from a patient's perspective about all this, some of the stuff we talked about. And then I'll open it up for questions. And just as a forewarning, if you see me disappear, that's because I have a hard deadline because some activities have restarted back in Manitoba and have to drive my children to one of them. So Sabrina Wong may moderate the remainder of the questions if they run after 5:30. So I'll turn it over to Kevin and then I will moderate the first few questions.
Yeah, thanks, Alex. And keep your eye on me, make sure I don't go too far here. Good afternoon. I just want to let you know that I've learned a lot more about our healthcare system than I know a lot more than I did 5 years ago. I don't think most people learn about the healthcare system until they need it. They don't take an interest in it because they've got so many other things going on, and they feel that once they do need it, they'll be dealing with professionals, and those professionals will take care of them. So they may have an annual checkup, and that being their only contact. So they, and I know this speaks to me, was totally unprepared when something happened that necessitated the system, a system beyond a yearly checkup. And it didn't go very well for me. And it necessitated the use, I'm sorry here, there were a lot of mistakes made which caused extensive heart damage. Now, I was counseled at that time to use legal system to somehow right those wrongs. But I couldn't see spending 7 years and countless dollars doing that. I felt it would be much better to work within the system to change, to suggest changes. And Alex and his group started off by giving me that opportunity. And that's really where my journey began. And that's what's brought me here today. I listened through the 3 speeches that you've made, and I'd like to just comment on something, and I'm doing this not representing all of the patients, but representing me as a patient. When I was listening to Jessica, one of the things that I noticed she said was meaningful patient engagement. I think that's really important. I know that's important. I know it's very important. And to have a meaningful patient engagement, you need to find a patient that can engage with others, have some ideas. You need to find that right person. And in doing that, you need to interview people in order to get some person that's going to fit. Last thing I think you need is someone just complaining about the kind of service that they've received. You also said strong patient voice. Again, very important. Positive ideas, not complaints from the patient. Better outcomes and better value. Well, better outcomes to me means better value. And modernizing the healthcare system with digital healthcare solutions. Definitely a strong believer, and that's the direction that we need to go for the patient. E-consultation being a prime example of that. Morgan, I like the mapping process that you were using. The team mapping, the note I made here, team mapping allows learning about each other in a patient-centered way. Yeah, I'm the consumer. I'm a patient. I'm the consumer. And what the consumer wants is service, and they want proper service, and they want timely service, and they want correct service. So if you can, in your research, keep that in mind, I think it would go a long way to meeting the needs of the patient. Your PACC map, to get people to discuss how they are going to work together. What a great model. And I hope it's very successful and works for you. I'm sure it has in the past. Team-based advisory committee. Again, tremendous concept. And the question I have down here is, have you got patient involvement in all these different areas? So you're nodding yes, and that's very positive. And for Jennifer, long-term care, the next chapter, you've adopted a person-centered care, and you're designating around designing around the person. That's very positive. When I hear those things, it just makes me smile, that this isn't, you're just not attempting to get a system that's efficient and effective, but it also meets the needs of the patients and not just the system. How am I doing for time here, Alex? Have I got about 3 more minutes?
Sure, go ahead.
Okay, thanks. He's never said no to me. Okay, so I've also, and I'll be very quick here, like what does the patient want from our healthcare system? What I want is I want mutual respect. I treat people with respect, and I ask that they treat me with the same respect. I respect their time, and as a result, I show up on time, and I show up prepared with my questions and my medication list, and if I need to, the history of my care. And what I'd really like to see is the same respect returned to me from the primary care provider and all the support people around that primary care provider. A patient, me, wants to be treated as an equal. And this is where patient-centered care comes in and is so important. We can call it many different things. I wanted to be treated as an equal. I want to have a say in what my care is, and I want this to be a collaboration. I want to be involved in the decisions that involve me. And I want to find out from the specialist what he thinks. I want him to tell me when I'm seeing him. I don't want him to write to the primary care provider, and then the primary care provider will tell me something like a quote, well, your specialist feels this. Well, geez, I just saw him a week ago. Why didn't he tell me when I was there? Like, so he didn't include me, as if it wasn't necessary to include me in what he was thinking. And those are the things that leave a bit of a sour taste in a patient's mouth. I want no harm as a result of my treatment. I want no errors made in the result of my treatment. I want the feeling that I'm dealing with a professional. And for the professionals, there definitely needs to be an attention to detail. And finally, I don't want to be treated as an inconvenience or the invisible person. I understand that you've had a long day, but so have I. And I've had thoughts that I was going to die. So please don't treat me like an inconvenience. And so that's what I wanted to share with you today. If you do go ahead, and I'm sure you have in the past, working with patients, really interview them. Make sure you get the right fit. Make sure you get someone that will be able to share not only their own situation, probably less of their own situation, but some outside, maybe business input. And I think that's helped in our situation with e-consultation, that I've been able to look at it from a business standpoint. And I try to keep Alex and Lori and Lewis focused on on the direction that we should be going. And thank you very much for your time.
Thanks very much, Kevin. I always enjoy when Kevin gets to speak because he grounds it in sort of, it's personal, but it's also thoughtful, and it teaches us that sometimes from the outside looking in, it looks a little different, the health system. We do a great job of following the opposite of good marketing, right? We overpromise and underdeliver. So we say, oh yeah, we'll cure your cancer, your heart disease. Well, actually, we'll kind of cause you some harm for a little while, and then maybe you'll be partially in remission. Okay, so I'm going to fire off with the first question, and this is from a person who has not identified themselves. So if you could pick one structural obstacle for provincial policymakers to tackle, what would it be and why? So I don't know if each of you want to try an answer at this, but I guess this is tricky because we're trying to distill, what's the, I guess, structural or policy obstacle that policymakers have to really hone in on. Does anyone want to start with that one, tackling that one? You're all silent in thought.
I'll go.
Go ahead, Jennifer. Go ahead.
I'll think about it from the long-term care perspective. The one I think is workforce. And in long-term care 25 years ago, people told me, don't go work there, Jennifer, you'll never have a career. And I don't think the last year has done anything to improve the situation. I think that the policy changes that have happened so far are minimalist, and we need to be ambitious about how we transform the workforce in long-term care to make it an appealing place to work, where we have education programs that prepare people to work with frail older adults. And that, if I post a position, I'm getting 25 applications or more for that role, rather than spending years searching for that one person who's willing to take it. So I think that the workforce issues in long-term care are huge, and I haven't seen a whole lot of creativity around how we're going to tackle this moving forward.
I mean, I think, Jennifer, to your point, if anything, it's made it worse, right? The pandemic has decimated the workforce, and lots of people have gotten sick. And I hope there's a bounce back where maybe there's a new understanding of how important that work is, and that people can be encouraged to take it on. But it's tricky. I wonder if there's anything that we learned in the pandemic that would sustain, that kind of, particularly long-term care. You mentioned some of the things weren't bad, right? Some of the things that happened were not all terrible, but I wonder if there's some of those things that might nudge forward if we kept them.
Well, it's going to steal my answer to another question, but at a very basic level, give people full-time jobs and pay them a living wage. I mean, this isn't rocket science. I've worked in care homes where the taxis are waiting for the care aides to get to their next shift, and they're working 16 hours and more sometimes. So if we don't treat that workforce properly, we're not going to be able to staff our long-term care homes. And so when people are yelling about minimum staffing levels, well, they would be great, but we can't achieve them with the way that we currently treat our workforce. So I think that the government, in terms of policy and structural barriers, this is one place that really needs to have a focus.
Yeah, you get what you pay for sometimes. So Morgan, the next question's for you. So I don't know if you want to double barrel and try to answer in part what the key obstacles are, while you sort of give us some insight about how, if you think mapping could be scaled up, the sort of mapping exercises that you described could be scaled up across sort of macro systems or large systems.
Yeah, I will, Alex. I'll answer the first one briefly. I think one of the structural things relates to Jennifer's comment, but it's the organizational barriers between members of the circle of care. So thinking of that talking about team mapping, the big circle around a patient are all the different people that are in my own healthcare system, but they might be across 7 different organizations. And even within one team, we might have multiple funding streams, et cetera. And that causes some barriers that I think we need to really think about where those fragmentations happen. And there's certainly places where that's going to have to happen because we can't, even though we're one payer, we're still got different organizations involved. But where those breaks happen, I think is a real challenge.
Mhm.
And then to go to my question here about scaling, I didn't mention it, but team mapping, by its nature, the value of it is a bit intimate. So rather than having one massive, everybody sort of hops on a Zoom call, there's 1,000 people and we all talk about how teams work together. The intimacy is what makes it valuable. The map itself is probably less valuable than the conversation that happens around the map. There's that idea of plans aren't as valuable as the planning to create the plan. But in terms of how we've scaled it, we've trained over 235 facilitators across BC. And so the existing primary care coaches that are out there, most of those and other people have been trained in the method. So it's I always say it's an arrow in their quiver. If it's a tool that might help a particular practice, they can offer to do that. And so that's how we've chosen to scale it. So we've created both originally in person and then of course virtual facilitator training, and all of our materials are online on our website to try to scale it that way. So people can dip into our library of personas. They don't have to create their own. We've got a library of almost 50 there. So that's how we've been able to scale that. The other pack mapping, we haven't got to scale. We're still doing most of it ourselves, or all of it ourselves right now. But I suspect it'll be something similar that we'll train some facilitators.
Okay, I'm going to ask Morgan your second question, and then I'm going to switch to my phone, and I'm going to ask that Mike Law or Sabrina voice the other questions. Oh, looks like the next one is still for Morgan. I think still has 8 votes. So Carolyn Still-Gray, whose presentation I really enjoyed yesterday, and I would love to get some of those slides. I tried to pull up a few from one of the papers, but it wasn't the same. Carolyn asks, can you comment about the shift to virtual and how it's impacted relationship building within teams and how they work through that process? I think that's actually very similar to sort of the follow-on to the question you just gave is how does the virtual aspect connect? And I'll be back in just a moment.
Okay, thanks, Alex.
No
So I think there's 2 parts to this. One is the virtual for everything else, which has made relationship building harder. Just because the natural flow of how things might happen, the hallway conversations, the meeting in the lunchrooms, and that sort of unofficial stuff that's so important is much less likely to happen. I don't know how many of us have lunch on Zoom unless it's during a meeting, as opposed to taking a break, clicking on Zoom and having lunch with a friend. I mean, I want to have a break from the screens these days. So I think that we're missing that. And I know a few people have done a good job of those little micro connections, but it is hard to do with the tools we have today. So there's that part, which makes things like team mapping and those check-ins, those team huddles, those things become more important because you're not doing it as you walk down the hallway. I was at my own clinic just yesterday, and I don't go in every week even right now because everything for me is virtual. And it was just, good to, even at a distance, say hi to some folks and talk about what was going on. So I think that's important. And I missed the second half of the question because it just got flicked off. But in terms of I guess it's the team mapping, the activity itself, I think you really have to structure. You can't assume that everyone's going to engage in the same way as if they're in a room. And as a facilitator, the tricks are different. So we generally, when we do these sessions, we have 2 facilitators virtually. One that might be managing the writing on the screen, because that happens in real time, and the other that's managing the conversation. And then we're both trying to look at the same time for people who are disengaging or maybe haven't had a chance to talk. So the whole dynamic of who's the loudest in the room, you want to balance that out. It's the same thing, but it's harder to do. Zoom makes it really hard because people who don't talk a lot get bumped off the screen, and you sometimes can not realize that they haven't said anything for a while. So I think having that sort of backup facilitator is an important piece for us, the lesson we learned with the actual facilitation.
Thanks, Morgan. So I'm going to be taking over the questioning now, and I'm going to spread things around a little bit. So Jessica, the next question I have for you, is demonstrating impact a tool for seeking more funding or deciding who to fund in the future?
Okay, great question. And I should say that, so demonstrating impact, and it's at various levels, right? So if we're talking about demonstrating impact of a particular research project or program, I wouldn't say that it's necessarily a tool for seeking more funding, but it absolutely could be, right? So if you can demonstrate your impact and use that as a way, whether it's funding through CIHR or to spread and scale your project program to a different setting, site, location, a different province, you can use the impact that you've shown as sort of like a lever, right? To whether it's getting in the door or getting your project picked up. So I'm not saying that it's necessarily a tool that CIHR would use to sort of figure out who to fund. Although obviously, again, if you're writing an application for a particular grant application, having that, being able to describe your impact would be highly valuable. But it's really about using it it's a knowledge translation, knowledge mobilization tool, right? So if you're thinking about policymakers and what they would be interested in, like, results are absolutely fantastic and really important, but it's getting at that other level of really understanding the impact, the change of the research or the program that's really important.
That's great. Thank you. I'm going to move to a question that's aimed at Kevin here. So Kevin, I agree completely that mutual respect is a key. The problem is that this isn't emphasized in the training of healthcare professionals. I'll turn to you for thoughts on ideas first, and then I'll turn to our other panelists for their thoughts as well.
Yeah, okay. Well, in my very simplistic way of looking at things, if it isn't emphasized in the training of healthcare professionals, why isn't it? That's my easy answer. Why aren't you, like, in your healthcare training? I think there is some training there for how to ask a question of a patient in order to elicit information about, their symptoms and what's bothering them. And I've been in a situation where I'm in a semi-private room and there's a sheet that separates myself and the patient beside, and I know more about this person's medical situation than the doctors do when they come in with their residents to ask the questions, because first of all, I don't think they thoroughly read the charts. Secondly, I don't think they know, even though they have had training, that if you don't get a response the first time you ask the question, frame the question differently and ask it again and practice that. Don't just come into the room and think it's just going to happen for you and you'll be able to do that. You need to practice that, and you need to learn that when you're going through your schooling. And I think that's the same thing with mutual respect. If you haven't been taught it by your parents, by your grandparents, by you then you need someone to teach you that. And I think it's got to be the whole approach that students get when they go through medical school. And it should start, if it hasn't started at home, it should start there. And you'd be surprised that if you I treat people the way I want to be treated, and 9.9 times out of 10 that happens. So just be kind to people, be nice to people, and they'll be nice to you. But it should start in your schooling. That's where I would start it if it hasn't already started at home.
Would any of our other panelists like to give a brief 1 or 2 line thought on this point here?
I'm gonna throw
Morgan, did you want to jump in, or I'll go? I think this is such a great question, and I think I wouldn't say it's not taught in health profession programs, and certainly in nursing. There's this idea of hard skills and soft skills, and how we culturally value different skills. And students have really high anxiety, so it's not surprising that they really sort of want to get those hard skills down, that IV medication, the different kinds of skills. And I do think it's a reflection of what we value. And so as they get through their programs, they're looking to master those kinds of skills. And how do we embed in our program also mastery around patient-centered and person-centered care? And then I think it goes on. I think it is around professional development, the type of culture that leaders foster in different organizations, how people are called out or called upon in their interactions. I think that we need to really foster that culture of mutual respect that I think Mr. Turner talked about so beautifully, because I think that we can get there. And part of that is around the partnerships that we even had, we're talking about in the previous session around collaboration and making sure that patient partners and family partners are at every table all the time. So I'll just leave it at that.
Can I jump in and just add one more thing? I think it also comes from the top. I think that, and again, this is from personal experience, being in a hospital and having a cardiologist bring these residents in, or even dealing with a cardiologist and the arrogance of the cardiologist, and maybe the individual needs that persona in order to get through the day and all the hardships that they see. But I tell you, it quietens the patients very rapidly if they get a sense that they're speaking to an arrogant individual. They'll clam right up. And I'll give you a quick example where the cardiologist said, well, you're on so many milligrams of this drug. And I said, well, I'm on that drug, but I'm really not certain if I thought it was less milligrams, and I gave him a number. He says, no, it's this number. And I said, I'm really not certain that that's the number, but it's in my chart and it's just outside the door. So why don't you have a look and then come back? He says, no, that's it. This is what it is. And I said, no, I don't think so. So, but his voice was raising in this altercation. So was mine. And so he came back 15 minutes later and apologized because I was right. It was less. I had the right number, but so there's that arrogance there, and maybe they need it to get through the day. Maybe it's taught. Maybe it's all part of the title. I don't know, but I think it also starts there, not just at the bottom, and really it does start at home.
Thanks, Kevin.
I would just add one thing to what Kevin said and sort of connect to what Jennifer's point was, is that teaching the golden rule is actually really hard. And I spend a bit of time teaching residents, particularly family medicine residents, and in some ways it's actually easier to teach the hard skills as a teacher than it is to teach the quote unquote soft skills. And we structure our medical curriculums in part around some of the things, the sort of low hanging fruit. And so it's not that they don't get taught, it's that we probably do a better job teaching the more technical aspects of medicine than some of the softer, so to speak. So it is definitely tricky. If there was an easy way, so to teach the golden rule, then someone was already a mature adult. I haven't found it yet.
Thanks very much for both of you for the response to that question. That was really insightful. At the risk of offending Diane Finegood, I'm going to combine both of her questions into one, because I'm going to ask it of all of our speakers as a last question, and essentially ask, how do you evaluate the impact of the efforts or the changes that you're making? And is that an important part of what you do? And is that and what kind of impact data do you have to suggest that what you're doing is actually working? So if all of our speakers could take a minute or so, and then I can wrap up on time. So Morgan, would you like to start?
Yeah, Mike, thank you. I think for us, we definitely do take that continuous quality improvement kind of iterative approach. And for the examples that I gave today, it has been more program evaluation than impact. in terms of impact on we're talking about hard and soft skills, hard and soft outcomes. We haven't looked at sort of hard outcomes. We have gone back to clinics and teams and asked them, how has this changed? So have you made decisions early kind of indicators based off of the team mapping or looking at the pack mapping at a community level? What did you come up with during the session, and did that influence later what your plans were? So we've looked at that level. And then a lot of our evaluation has been that sort of QI cycle of how can we do this better? How can it be more impactful? How can we change what we're doing? I think that's the approach that we've taken with the things that I've presented today.
And Jennifer or Jessica, would you like to add to that?
I can take it from the CIHR perspective and the impact data. So, and Diane, fantastic question. And it's a bit of a challenge, especially if you think about, so much of our research funding goes out, and it's 4 or 5 years of funding, and then we get an end of grant report. So many of the initiatives that I spoke about are actually either still being funded or in that last year where we're waiting on reports. But I will say, in particular one, I think as an institute, we're shifting away from more standardized reporting to more individualized reporting for programs so that we can really get at this impact piece. And we're trying to do a better job of doing that. There are some programs, like if you think about the Primary and Integrated Healthcare Innovations Network, SPOR has some fantastic data because there was a lot of reporting that went on with those programs. And another program in particular that I would mention is the Health System Impact Fellowship. And Dr. Meg McMahon has been leading the way on this. And we have quite a bit of data on that particular program, especially because it's an annual program and the individuals are in it for 1 or 2 years. So there is a faster turnaround, and we've put a really great emphasis on trying to get at the pieces of that program to really evaluate our own impact.
That's great. Jennifer, the last word is yours.
Yeah, thanks. That is a great question. I think in long-term care, we need to be looking at measuring the quality of resident care and quality of work life, and how do you link those two together? We do a lot of data collection around resident outcomes, but we don't always have good ways of using the data. So also making sure that we have capacity within the system to analyze and interpret what we're finding out so that we can make improvements based on that. So that would be what I would say from the long-term care perspective.
Great. Thanks very much, Jennifer. So it's a pleasure to thank Alex for chairing this session, and to Morgan, Jennifer, Jessica, and Kevin for taking the time to be with us and speak, and for the audience for all of your really excellent questions. So thank you very much. At this point, I am going to turn things over to Morris Bearer, who is going to introduce our last speaker.
Thanks, Mike. Hope everybody can hear me. Great to see so many of you still zoomed in for our final session of this year's conference. I'm mostly retired former director of CHSPR and a faculty member in the School of Population Public Health at UBC. But I never miss a CHSPR conference. And it's my great pleasure this afternoon to be able to introduce our final speaker this year, Stephen Lewis, joining us all the way from Melbourne, where it's approximately time for his third morning cup of coffee, I venture. Stephen is probably the only non-CHSPR affiliated person who's actually participated in more CHSPR conferences than Walter Wodgis. He's a health policy and health services research consultant, an adjunct professor of health policy at Simon Fraser University, and a clinical professor at the University of Saskatchewan. Even from down under, he's continued to pen cogent pieces for Canadian media outlets. I'm sure many of you have read them. And we hope to lure him back home one of these days. This afternoon, his remit is to distill the highlights, obviously, from the superb presentations and discussions of the past couple of days, and to leave us with some key policy implementation and research options for improving the integration of care. So without further ado, I'll hand off to you, Stephen. Is Stephen there? He's got to unmute.
All right.
There we are.
Good.
You're good.
Sorry. All right. Sorry. Well, thank you, Morris. Great to see you, and great to see all of my friends at CHSPR. And thanks to all of you who are still hanging in for this session. I learned a lot in these 2 days, and what I want to do is not repeat the key lessons which you're perfectly capable of absorbing yourselves. There are some nuggets that emerged here that I think maybe need a little further elaboration. And by the end, I want to plant some ideas with you. I'm not confident that I'm right about all of these things, but I think I have a couple of suggestions for things to think about to see how we can move forward on this seemingly intractable problem of how we get more integrated care. And I'm going to begin with the sentence we've heard so much about Canadian healthcare and even internationally, which is, the care is really excellent, it just wasn't integrated enough. It seems to me how we understand and respond to that sentence pretty much tells the tale of how we're going to do here. Because if the care is truly very good or excellent, then it has to be, by definition, integrated enough. Maybe some care doesn't need integration, but a lot clearly does. Or we're kidding ourselves that the fact that it isn't integrated enough really means that it can't have been good enough. I think it is more the latter, especially with respect to the populations that were usefully defined by Walter and others as what the core of this is really about, which is people with multiple chronic conditions over a period of time. And those are the real challenges. So if we took all of this really seriously, if everybody who worked in healthcare absorbed the data on our performance in those difficult areas, which is at least now half of the business of the healthcare system, there would be an existential crisis. And there is an existential crisis, but I think it's mainly on the, I'll just paraphrase it by saying it's the Roberta, Mary, Kevin perspective of the world, the personhood side of the world. There is a burning platform for people, patients, caregivers in those categories in particular. And there may be burning platforms on the supply side, but they're different burning platforms. There are burning platforms like, I don't have enough OR time, or the nurses aren't doing what I'm telling them to, or I can't get that test done rapidly enough, or I'm working too hard. Real problems, I grant you, but they're not the same problems. So I don't know that we have a meeting of minds on the urgency of solving the integration problem. So just before I get to what I think some suggestions might be in reframing this a little bit, I want to just confirm that what the problem is. PG led us off, and it was nicely bookended by Tim and others. Politics matters here. This is fundamentally political in a capital and a small p sense about who gets what, where, when, and why. And there are competitions for hearts and minds, resources, and so on. So that's the general context. And it is also a fact that I think many of the presenters alluded to, which was that integrated care exists, but it's optional. I mean, it's nice when we have it, when we celebrate it, when we get it, but clearly we don't have to. The supply side does not have to deliver integrated care to sustain itself. So it's like every other phenomenon in the world, you get early adopters. And the question is, will it scale and spread? And I think the evidence would suggest not very well in this area, because it's devilishly hard work. It's not only devilishly hard to achieve because of its complexity, relationship-based moving parts phenomena, it's also difficult to sustain. So even when you have a great example like Canterbury, you can lose it. You can scuttle it. It can fall apart for all sorts of reasons. So that's a true challenge here. And we do know, however, that there are lots of great people, many of whom presented ably at this conference, who are working on it, and they're doing great things on the ground. And it's described so often as a ground-up phenomenon, ideally accelerated by, enabled by, promoted by policy. And I'll talk a bit about that later. But yes, there are on the grounds efforts. But as people like Adira and others have said, you know, the instinct of most providers is not to want to do it. And I think that's a pretty fundamental insight that Adair mentioned, Walter mentioned it almost en passant, but I think it's kind of fundamental. And we can say they don't want to do it because they're narcissists with no emotional intelligence. I don't think that's the reason, or at least it's not the exclusive reason, and it's not the reason for most. I think there's a deeper reason, and we have to address that and take seriously that deeper reason about why people are reluctant to engage in what they intellectually understand needs to be done. And even that needs to be done because they know, if not on the surface of their brains, at least subconsciously, that somehow this is not working out, that we're failing. And I think getting at that is one of the ways forward, which I'll talk about a little bit later. We also realized, and of course this is a policy conference among other things, and policy matters, but it can only do so much. In the necessary and sufficient condition continuum, good policy is necessary. It is certainly not sufficient. And the policy may be too general to accommodate too much. So it may be more almost aspirational than actual policy. So I would urge us to think about, does the policy need more teeth, more precision, in order to send the signal and to establish a context where integration is more likely to occur because it is more embedded in what people are? I will use the term accountable, but I am persuaded that responsible is probably a better way to phrase it. But that people at least sense a real commitment to an obligation to achieve. I think that's quite possibly true, but something to think about. We also learned that interorganizational collaboration is essential and it's fundamentally local. I think that is also true. So as others and many have pointed out, there is an intrinsic competition built into organizational structures in healthcare. And when they are competing at the same time as they're supposed to be collaborating, it creates a fundamental dilemma. We need to figure out a way to address that dilemma. And again, I have some rather probably overly simplistic views on that, which I will again get to later on. So let's get back to why there is a lack of progress. And I'm just going to emphasize the one thing about what is it about in providing integrated care that many providers don't like. And I'm using all providers. The conversation has been largely about physicians. I accept that, but I think it's not just physicians. And I think the reason fundamentally is that it implies interdependence. It applies being responsible for achieving things beyond what you specifically do and contribute. And it involves a lack of control, loss of control. All of those things are a bit alienating and forbidding. It is natural to recoil a little bit from those environments for most people. We are not, from our formative processes in the sociology of healthcare, taught very much about the essentialness of interdependence. We're taught to be autonomous professionals, or those of you who are caregivers are, autonomous professionals with a domain of practice where you have deep expertise in your area, to which others should defer. That is different from saying, I'm a piece of the puzzle. The puzzle is meaningless without all of the pieces being present. And if we don't fit together, the picture is disfigured. It doesn't mean anything. It's not coherent. The person, as Roberta said, is lost in the shuffle. In addition to that, we are still, despite the admirable conversations we have about person-centeredness, holistic care, health science education and practice and financing and accountability is still built on a largely biomechanical model of the human species. And that specialization, which has exploded in the past century and a half, has been the preferred vehicle for dealing with it. And the ironically entitled personalized care revolution is actually not about the person at all. It's about the biological characteristics that being increasingly understood and individualized will lead to increasingly better specialized, sophisticated technological and pharmaceutical interventions. The person is actually even more lost in that construct, even where it's highly successful. And I, for one, hope it will be successful in a lot of ways to address purely biological phenomena. So I'm all for that, but it does not actually address person-centeredness in the way that has been meant at this conference. So there's a conceptual issue there about specialization and fragmentation that is as much a risk factor as it is a boon to healthcare. And I don't think we know how to deal with that very effectively. So maybe we need, in my concluding remarks here, to rethink the exercise a little bit. And I'm going to make a pitch for two things. One is, I think we need to see integration as a little bit more than the way we see it now. We see it as a combination of structures, and Walter Wojcic's overview emphasized the clinical integration is the main structural approach to it that actually interfaces with the person, the patient, but also interorganizational and structural kinds of relationships. We see it as financial resources and incentives. So again, as was pointed out in Ontario, it's great that Ontario health teams have money so they can pay doctors to attend meetings. The incredible irony that you would have to do that shows how fundamentally screwed up we are in how we pay people to deliver health care, when doing what is a part of every normal person's job, which is attending meetings to address complexity and communicate, is somehow an option for which you should pay extra. And if you don't, they won't attend. It's pretty weird, and we need to get our heads around that. We think of it in terms of policies and ensuring that the well-functioning parts work together to meet a person's needs. I'm going to suggest that while it is all of these things, that there are more fundamental issues. And one is, as I mentioned earlier, that if we really want the person to be at the center of healthcare, and we really want to deliver good care from the perspective of the person as well as the supply side, and negotiate what that means, we need to rethink whether or not we have gone too far over to specialization, both organizationally and in terms of who is delivering the care. So I'm going to make a pitch for a return to generalism. And by generalism, I mean a mindset and a perspective, as well as a set of capabilities that I think is essential if we're going to really focus on an integrated series of care interventions that work for people in a relationship-based way over the long haul. And I don't just mean this is about primary care. I mean every specialist, every person who works in the system has to have a generalist perspective where the whole person's context, environment, values, preferences, circumstances are always kept in mind, even while providing very specialized partial interventions to deal with very specific problems. If that gets lost, I think specialization becomes as much a risk factor as it is a benefit to the patient. And if we view it that way, the specialization is actually in itself a fragmentary approach to providing care. However essential and however valuable, I think we will restore the primacy of that fundamental relationship, usually with primary care, and to make sure that that perspective is integrated into the electronic health record, into the evaluation of whether the interventions and the care is successful, in the patient experience and the patient conception of what is actually needed. So in a sense, I'm suggesting that the problem, while in many ways externalized to structures, to organizational structures and relationships and so forth, the biggest integration needs to take place in here. It's in the brain. I think we need to think on the supply side of having an integrated concept of what the person is, and then mapping that concept onto how we do and conceive of our work. I think that's going to solve half the problem. I think if providers generally thought in an integrated way about people, and if they were lumpers as much as they are splitters in terms of how they approach their work, I think the integration that needs to happen across teams, across organizations, will occur more naturally. In other words, I think it will be an inductive process that stems from the fundamental recognition that this is a whole person, and that everything I do has to relate back to that whole person's experience, context, values, preferences, as well as the technical aspects of healing and fixing, especially when they're very discrete problems. I think that will solve some of the problem right there. I think it will immediately lead people to think, of course, this is an interdependent business. Of course, I cannot do this alone. Of course, health cannot do this alone, since 75 to 80% of health outcomes are influenced by the social determinants of health. Well, that fundamental statement, which every student knows by now, has to percolate through the training. And I believe that's sort of the things that Kevin was getting at when he was talking. And finally, I want to address that issue that was raised in many of the proposals in the presentation, which is trust and interorganizational trust among them. Well, maybe one of the reasons that we require so much interorganizational collaboration and trust is because there's too damn many organizations. Look, we still have a very fragmented structural approach to healthcare. Regionalization was supposed to fix it, but regionalization left most of the, frankly, unconstructive social and political capital in place in these organizations that retain their own fiefdoms, their own perspectives, their own notions of performance, of success, and accountability, and their own competitive instincts. So it didn't work, and it didn't actually strut its stuff well enough before it was declared a failure, and now we have retreated from it. And then I want to conclude one more thing on that fundamental issue of trust. Of course, people have to trust each other. And of course, people need to actually get in the same common space where they are comfortably interdependent and openly listen to the various perspectives. But as others have said, and I think Tim really brought this home in his presentation about the factors at play politically and the tendency to interpret accountability in a very accounting-like way, which unleashes the tendency to micromanage. It's not a trusting environment. We say we want a system that is flexible, adaptable, and can respond to people's needs with agility, where you can move resources around flexibly in order to meet emerging needs. But we don't trust the system to do that. We don't trust the people to articulate how that ought to come about. So we essentially hamstring and demoralize and squelch the productivity to deal with the complex problems of the families and people that Roberta and others visit every day. So governments are a key part of the solution here. Trusting the experimentation. Remember, PG said at the beginning, our pilot projects are designed not to fail. And that's a bit of a tragedy because it means they're too safe and they're unimaginative and they don't aspire to enough. You have to walk the talk on trust. You have to say, here's your budget. Here's your global budget. Here's 3 things we would like you to accomplish. Use your ingenuity to do it. We don't actually want to get into the weeds of how much you're spending here and how much you're spending here. And you don't have to come back to us every time you want to reallocate 2%. So you put all those things together with the cognitive revolution in here back to generalism and a truly integrated perspective. And you enhance the conditions of trust at the personal level, at the organizational level, and at the policy level from government. And I think we have a real shot at moving forward on this. I think the pandemic has shown that unlike the tradition in Canadian healthcare, you don't have to move at the speed of a snail. Virtual care is now the norm after having been fought off and thought to be impossible for 25 years. It took place in 6 weeks. There was a new collective agreement in place in many provinces in 5 days to accommodate it. So let's not waste that opportunity to think about integration in a new way, and I think we'll be fine.
All right. Thank you, Stephen, for your customary amazing ability to pull the large nuggets out of a gold-littered stream bed. and then to give us the benefit of your insightful analytical lens applied to what you found, or rather, I guess in this case, heard. We've been left with tons to think about, and happily just a few thorny issues still to resolve, which is always good. We obviously look forward to seeing you in person at next year's conference. Here's hoping. So thank you very much again. And with that, I'm going to hand the virtual mic back to Mike for a few closing remarks.
Thanks very much, Morris. I'll make this quick for everybody. As with the case with Morgan Price, last year's CHSPR conference was also my last event in real life. And funnily enough, I shared the same thing as him as I went home that night, collapsed on the couch after having organized the conference, which is a ton of work, and said to my wife, I don't think we'll be doing a conference again for a long time. Thankfully, that's not the case. And over the past couple of days, I've really enjoyed hearing some really excellent speakers share their thoughts with us. And while I've truly missed seeing and catching up with so many of you, it's been a real pleasure to see a lot of familiar names in the attendee list. So thank you for making the time to come and join us. And hearty thank you to Sabrina, Dawn, and Joyce, the rest of the CHSPR staff who helped make this event possible, and for making it operate so smoothly in this new environment for us. Thank you to our speakers for sharing. Thank you to our sponsors for making this work from a financial standpoint. And thank you to all of you in the audience for joining in and sharing some really excellent questions that we've been able to share with our speakers. Just a quick note, you'll get a conference evaluation in your email tomorrow, and we always appreciate hearing back from people, their thoughts on how we can make this conference better in the future. So with that, fingers crossed that this time next year we'll be back in real life, and that we'll see all of you at the 34th annual CHSPR conference next March. Thanks very much, everybody, and I wish you the best for the coming week.